where things sort of break down. I think that for now, the boards would say start after stabilization. So I think that would be a reasonable thing to start, that they could ask you. Between 200 and 350, it's recommended to start, and there's accumulating evidence that it's better and better to start earlier. Over 350, it's a decision between you and the patient. So that's the thresholds for now, at least. Finally, what is testable in the boards has caught up to clinical practice. For a long time, there were agents that were on the approved list that never in a million years would we start now, and yet they were still considered to be appropriate for the boards. The current testable recommendations are here. It's Truvada, which is a combination pill that has 2 agents in it, and then one of these other ones. If you have to know one, I would say efavirenz. So Truvada and efavirenz, or tenofovir and tricytidine and efavirenz. The other ones are kind of pushing the envelope of things to memorize, but realize that it's generally still the recommendations are 2 nucleoside or nucleotide RT inhibitors, 2 NRTIs, plus one other something. Okay, that one other something can be efavirenz, which is a non-nucleoside RT inhibitor, or it can be a boosted protease inhibitor. So ritonavir is a boosting agent that jacks up the levels of the other ones so that you need fewer pills each day. Raltegravir is a new kid on the block from 2007. It's a new agent, and it was recently, the 2009 update was that it could be used as a first-line agent. Cryptomeningitis, the important thing here is to get serum cryptoantigens. India Inc. Is never used anymore. The mortality comes from increased ICP, and the mechanism is that the bugs actually block up the arachnoid granulation. So you get increased, or you get blocked drainage, but the CSF production is still maintained. So you just get stacking of the CSF, and so the treatment is to drain. So repeat LPs every 48 hours, so serial LPs until the opening pressures are normalized. In some cases where things are severe, you can have neurosurgery place a lumbar drain for temporary drainage, and then it's antho and flucytosine for 14 days, and then switch to oral fluconazole. I put this up here. I think I would look at this at some point because there are some things that could come up. The most important things on this slide are that tenofovir can cause a creatinine elevation. Nevirapine is hepatotoxic if your CD4s are high. So if you're given an option, if somebody has a needle stick and you're asked what agents do I start, nevirapine is always the wrong answer. Okay, so never, ever, 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 ever nevirapine for post-exposure prophylaxis for PEP. And then for some reason, and it drives me crazy, but indinavir, this question comes up all the time, that indinavir causes kidney stones. Nobody's on indinavir anymore, but it is such a profound association that they still throw it on, and they still sort of consider it to be fair game. I put this up here also. Just look at it at some point. It's the most common side effects for antimicrobials, just so that you're aware of some of the things. Septic joints, I'll let you kind of read that one. Lyme has a preference for large joints, so knee and shoulder, and that's a picture of one of the knees. The effusion is greater than the pain, so these joints don't hurt, they're just blown up. And then diagnosis for Lyme relies on serologic testing. Gonorrhea, you get tenosynovitis is the issue with gonorrhea, so you'll get pustules over a tendon. And diagnosis is confirming genital or extragenital GC. So think about the throat as well. GC does hang out in the throat. These are the STD treatment guidelines. I would go through them and sort of memorize them, unfortunately, for basically uncomplicated things. I'll go through just random important points. One is that for gonorrhea, we don't treat to cure gonorrhea itself, we cure to prevent disseminated disease. So dissemination of gonorrhea actually can be quite bad with very destructive arthritides and tenosynovitis. So the treatment here, most cases actually will resolve spontaneously. but treatment is geared toward preventing systemic complications from it. If you have gonorrhea, you always treat for chlamydia because you can't tell if chlamydia is there or not. The gonorrhea is overwhelming, so you cannot tell if chlamydia is there. So it's always a gram-nasal throw that should travel with this. And quinolones cannot be used any longer for treating gonorrhea. So time was when they were quinolone sensitive, and now the prevalence of quinolone resistance in a gonococcus is high enough that CDC 3 years ago now said no more quinolones for GC. C-tract, again, is azithromycin, or you can do doxycycline for 7 days. PID and Fitzhugh Curtis. Fitzhugh Curtis is a purulent perihepatitis from either chlamydia or gonorrhea, actually. If they're pregnant or if they have cervical motion tenderness, if they're pregnant, then you have to admit them. And ceftriaxone, and then doxy and flagyl to treat all of the possible causes. And the flagyl is there for anaerobes that may ascend from the GU tract. Syphilis, the most important point is that anything that's younger than latent syphilis can get 1 shot of penicillin. Okay? So if it's primary, so you have chancre, which is a very unusual presentation, actually. The most common presentations are secondary syphilis, which is palms and soles rash or truncal rash. You can get systemic sequelae as well, including a syphilitic hepatitis that gives you a cholestatic picture, but the alk phos is elevated out of proportion to the bilirubin. All of these can be treated with a single dose of penicillin. Latent is when you have basically syphilis of an undetermined duration of time. If you have somebody who's acquired it within the prior year, then it's early latent. Realistically, we wind up treating a lot of people for late latent, and most of the in-house consults that we would get late latent treatment, just because very few people have annual RPRs. Neurosyphilis requires IV treatment for 14 days. And this is one of the rare circumstances where there is really no appropriate alternative. So if they are penallergic, you desensitize them in the ICU and you treat with penicillin IV. Herpes, blah, blah, blah. Trick, you should know what Klucel looks like. And flagyl. And remember the disulfiram reaction with flagyl, that you'll start vomiting if you start drinking with flagyl. Hep B, you should look at the window period. This is, it's like a tricky, annoying thing, but there is a period of time after acute Hep B infection where the only means of diagnosis is to capture core IgM or anti-core IgM. So take a look at this table at some point. And you can certainly circumvent all this by getting DNA, but they still want you to know the serology and how to interpret serology for Hep B, not so much Hep C. In the last couple of minutes, endocarditis. In 2007, the guidelines changed really completely, and so this is very much fair game. There are a very few things for which prophylaxis is reasonable, so including prosthetic valves, a prior history of IE, if you have congenital disease that's been repaired or unrepaired, and cardiac transplants should get prophylaxis. Dental procedures in general, if you have a significant, it basically has to be dental surgery, so really fairly involved. Deep cleaning kind of pushes the envelope because there usually is some incision of the gingiva that happens, but that would be reasonable to prophylax. Everything else doesn't get prophylaxed anymore, including GU procedures. So that used to be a question about giving like aminoglycoside or something, or amoxicillin peri-procedurally. You don't do it anymore. Malaria prophylaxis, the most important question is, can you use chloroquine or not? There are very geographically restricted areas of the world where chloroquine is okay. So in North America, basically, North America and South America, and then Turkey to Iraq, everywhere else you cannot use chloroquine. So either remember the parts that you can use or the parts that you can't. But it's very small areas that you can use chloroquine. The preference for travelers is Malarone, so it's helical proguanil, then doxy, then mefloquine. Mefloquine makes people psychotic. Doxycycline gives them photosensitivity, so this is unpopular for travelers in sunny places. And then Malarone is actually pretty well tolerated. The hitch is that you got to start it before you leave, and you have to continue it for a week after. But the same is true for doxine and for methicillin as well. Immunizations, don't ever give a live virus something to somebody with a low CD4 count. So live attenuated flu, some flu myth, varicella vaccination, or zoster. MMR is a live vaccine, and yellow fever is also a live vaccine. Precautions. You should know that varicella is an airborne thing. So if somebody has shingles, they should be on airborne. If you yourself have had chickenpox or the vaccine, you don't need to have precautions on, although most of the hospital epi people say to do it anyway, just to keep up appearances, really. And then, well, don't say that to Dave Weber because I'll get fired. And then droplet is kind of other things, contact. And then shingles, you can come off airborne. The questions about when to discontinue stuff will come up sometimes. So shingles, you can come off airborne once things are dry and crusted over. For C. diff, you can come off C. diff precautions once the diarrhea has stopped. And you don't do test of cure for C. diff. It's not appropriate to do that. Flu, honestly, I have no idea what they're going to ask because this is no longer an entity. So what was seasonal H1N1 is no longer here with us. It's been replaced completely with 2009 pandemic flu. So the sensitivities, this was a question that H1N1 was resistant to oseltamivir but sensitive to zanamivir. But now all of the flu A's that are currently in circulation are sensitive to the neuraminidase inhibitors. So it's no longer kind of a gotcha question. But I don't know if it's too early or too young to be on the boards. And basically the adamantanes are dead. There's no use for them clinically anymore. Meninge, everybody always wants to get, if you're like within a mile and a half of the person who has meningococcus, they all want to get prophylaxis. The right answer is that it's only people with prolonged exposures. So the dorm roommate or the boyfriend, girlfriend, significant other, but not classmates, not casual contacts, not the people in the cafeteria. So it's only close, prolonged contacts. And people that have been directly exposed to oral secretion. So the EMS people that did the intubation, or the ER staff that did the intubation, or the respiratory therapist. Those people warrant prophylaxis. The rest of the people that were in the waiting room, no. Unless it's RER and they were sitting there for 8 hours, and then maybe. So the RIS is the drug of choice, but you can do Cipro once, and most of the time we actually do Cipro once because it's a one-time deal. Prevention of ventilator-associated pneumonia, the most important thing is keep them semi-recumbent, especially while they're getting feedings. I'll let you kind of read the rest. And I think this is the last most important thing, which again is something that you should be aware of, is that post-exposure prophylaxis for HIV does work. The order of risk increases with the bore of the needle. So a scalpel is basically zero risk because there's no blood stuck to the steel. A hollow bore needle, a large one, so bone marrow would be the highest risk, then sort of a spinal trocar, and then hypodermics would be lower risk. But any of the needles are higher risk. Then scalpels and suture needles are the absolute last because it's so tiny a surface area. You start them within 72 hours. That's the right answer. Ideally within the first 20 minutes. And it does work. There is some data to support giving dual nukes by themselves, so basically just Combivir, which is AZT and lamivudine, or Truvada, which we mentioned before, which is tenofovir and. The current guidelines say to basically give them HAART. So you would do combo treatment of 2 nukes and a boosted protease inhibitor, or efavirenz, although this is sort of second line. And again, no nevirapine because it will cause hepatic necrosis, and people died in studies where they gave people nevirapine and high CD4 counts. Okay, this is just a whole bunch of pictures, so I'd encourage you to look through them because the board does have pictures, and ID stuff is really easy to get pictures of. These are bed bug bites. This is strep pneumo, so the halo and strep in pairs and chains. Shingles, right? Ramsey Hunt, remember Ramsey Hunt, facial nerve paralysis with ear pain and loss of sensation on the tongue. That's from zoster reactivating in the face.